Hi and welcome to the positioning for the pelvis. We are going to learn a few different views of the pelvis that we can take during radiography. Remember how I told you about the angle of that hip sitting back, the greater trochanter? Really important to roll the toes so that they're touching, so you're going to make a TP out of the toes when you're doing the pelvis or the hips. What this does is it pulls this angle from a 20 degree angle and pulls that greater trochanter so that it's in profile. So here you can see when we take that right leg and we turn those toes in, it positions that greater trochanter so that we're able to visualize it. If you throw that leg all the way out, the lesser trochanter becomes in profile. So when we take pictures of our patients, when you have the toes pointing straight up at the ceiling, you can see the lesser trochanters, but those greater trochanters are now becoming superimposed. As we start to flex those toes out, again, it brings that lesser trochanter into profile, but it's not bringing that greater trochanter into profile. So when we position for the AP hip or the AP pelvises, we want to make a TP, so we have them touch their toes together, so it forms this triangle. When we do that, it pulls those greater trochanters into profile. So here again, you want to make sure those greater trochanters are being pulled out, and then you know you have a good radiograph. Here's one where the affected limb is falling out to the affected side. When that does, you can actually see it starting to look more like a lateral position of the hip and not so much of an AP. We can use gonadal shieldings when we're doing pelvises. So if you have someone who's really young, you may want to place this on them or ask their parent or them to place that on themselves, and that will help protect that region while you're doing the radiographs. So these are a couple examples of different ways to position those gonadal shields. Alright, so for an AP pelvis, you're going to have the patient position their toes so that they're touching and making that TP. Your central ray is going to be midway between the level of the ACIS and the symphysis pubis. You're going to want to place your cassette in so that it's crosswise. You're using a 14x17. A good technique is usually about 80 kVp. Mass is usually about 20 mass. Here's an example of the AP pelvis once you've taken that radiograph. You're using a 40-inch SID. You're using the grid. We're going to have a large focal spot because of the size of your patient. Greater trochanters are going to be in profile from touching the toes. So basically when you put your image receptor in crosswise, you're going to come about an inch above the iliac crest. So the top of the cassette is going to fall about an inch above. The AP bilateral frog position, you're doing exactly the same thing for centering. The only difference is you're going to bring their legs up so that it looks like frog legs, and then you're having them abduct those legs out to the side so they fall about 40 to 45 degrees. Central ray is still going to fall about an inch superior to the symphysis pubis. So once you have your AP positioned, the only thing you're doing is raising their legs up and dropping them out to the side. So on an AP bilateral frog pelvis, it's going to look something like this. Technique does not change, but what does change is the position of that greater trochanter is now superimposed. Lesser trochanters are pulled out. Here's an example of the axial outlet projection, which is also called the Taylor method. For positioning, 20 to 35 degrees cephalic for males, 30 to 45 degrees cephalic for females. Again, you're going to find that symphysis pubis. You're going to center about an inch to 2 above that. You are going to elongate your film for this one. So your picture is going to look something like this. See how your obturator foramina are now elongated, and they're going to be magnified. You still won't have any rotation of the pelvis, but it does a nice job of opening up this region of the pelvis. Same technical factors. Inlet view, you're going to use a central ray of 40 degrees. You're going to actually come through the ACES for this one. Still using your 14 by 17, 40-inch SID grid. All of those factors are still the same. The only difference is that extreme angle causes that elongation. And look at how much we've elongated that pelvis. We don't do a lateral pelvis, but your book does talk about it. Sometimes you'll see these done on kids, and they're looking to see if there's superimposition of those hips. So this one's basically done with the patient laying up on their sides, their legs are curled up together, and then you're going to take a picture of that. But your book has it in there, so I'm giving you that as an FYI. But basically, inlet, outlet, AP, and a frog leg pelvis are the 4 views that we're going to do.